This presentation is going to cover the concept of perfusion. This is an overview of the concept itself. The essential function of the cardiovascular and pulmonary systems is to provide a continuous supply of oxygenated blood to every cell in the body. The physiological process of perfusion requires the heart to transport and distribute blood to every cell in the body. Changes in perfusion affect all human functions, including self-care, comfort, mobility, fluid volume status, respiration, and tissue integrity. Impaired perfusion may also affect self-concept and role performance. The process of hemostasis is your body's normal reaction to an injury that causes bleeding. This reaction stops bleeding and allows your body to start repairs on the injury. This capability is essential to keep you alive, particularly with significant injuries. However, in uncommon cases, the processes that control hemostasis can malfunction, causing potentially serious or even dangerous problems with clotting and or bleeding. So hemostasis is that process by which the body slows and stops the flow of blood. It is essential to perfusion. 3 overall steps are involved in the regulation of hemostasis. The first step is vasoconstriction. Vasoconstriction is triggered by substances that are released at the site of injury and also by nerve impulses from the pain receptors. The second step in hemostasis is platelet plug formation, and this is responsible for closing the hole in the blood vessel. Again, this is just a temporary solution to the problem. Secondary hemostasis involves the coagulation cascade, which are a series of events involved in clotting or coagulation, and this occurs within the liver. I should say that the clotting factors are synthesized in the liver. And the coagulation cascade needs to occur, especially when there is a larger injury to the blood vessel, when the platelet plug itself is not adequate in closing up the hole. There are 2 pathways within the coagulation system, and those are the intrinsic and the extrinsic pathway. This is a simple version of hemostasis. The steps that are involved include the vascular spasm, which narrows and the diameter of the hole that's in the vessel wall. And then we have the formation of a platelet plug, and this is a temporary plug. And finally, we have the formation of fibrin, and the platelets together with the fibrin forms a scab, so to speak, and eventually that is remodeled and formed back into the original tissue. Now, one of the organs that's intimately involved in the coagulation process is the liver. The liver is responsible for the formation of clotting factors 1, 2, 5, 7, 8, 9, 10, 11, and 12, as well as proteins C and S. When there is pathology to the liver, you can have a lack of coagulation factors. A lack or even a depletion of coagulation factors can lead to hemorrhage or bleeding. A decrease in coagulation factors typically means that there is severe liver damage. We can also imagine our patient who has end-stage cirrhosis of the liver. When there is severe liver damage, that individual will have a decrease in their coagulation factors because the liver is normally responsible for synthesizing them. So a diseased liver or sclerosis of the liver, that liver will not be able to make an adequate amount of coagulation factors needed for clotting to occur. These clotting factors are plasma proteins. Okay, they are made in the liver, but they are then put out into the liquid portion of our blood so that they can address any issues, any injury, vascular injury that is occurring throughout the body. The function of the coagulation pathway is to keep hemostasis, which is the blockage of a bleeding or hemorrhage. Primary hemostasis is an aggregation of platelets forming a plug at the damaged site of the exposed endothelial cells. Secondary hemostasis includes the two main coagulation pathways that you see on this slide, the intrinsic and extrinsic pathways that meet up at a point to form the common pathway. The common pathway ultimately activates fibrinogen into fibrin. And it is these fibrin subunits that have an affinity for each other and combine into fibrin strands that also bind the platelets together and stabilize that platelet plug. So notice here at where you see the factor 10A, that is the start of our common pathway. Okay, and that activated factor 10 is responsible for converting prothrombin to thrombin. And then thrombin, once it's activated, it allows fibrinogen to be converted to fibrin. And the fibrin is what cross-links and makes this fibrin mesh. The fibrinolytic system is designed to cleave that fibrin clot into soluble fragments. Here we see a simplified fibrinolysis pathway. This process is initiated by the release of tissue plasminogen activator, or TPA, or it can be activated or initiated by the release of UPA, which is your urokinase plasminogen activator. And those are released by the endothelial cells at the site of vascular damage. Plasminogen activation by TPA or UPA generates the fibrin-degrading protease plasmin. Plasmin degrades the fibrin clot into fibrin degradation products, which is abbreviated FDPs, that include D-dimers. So fibrinolysis is the breakdown of the clot. This occurs naturally all the time within our bodies in response to the formation of a clot. Your body will break down those clots that form. And what is left from this whole process are these degradation products, these fragments that are left after the fibrin is broken down. And we can test the blood for these fibrin degradation products. Frequently, a physician will order a D-dimer. And what does that indicate? A D-dimer or a test for FDPs indicates that the patient has a clot somewhere because the body is breaking it down. There's evidence to show that the body is breaking down the clot evidence that fibrinolysis has or is occurring. So in an indirect way, the presence of FDPs or D-dimers indicate that the patient does have a clot. Okay. But talking about perfusion and an overview of perfusion, it is important for us, or for nurses, to consider genetic influences on the health of an adult patient. Okay, because genetics does influence perfusion. And on this slide, we see an example where women are at greater risk of developing heart disease after menopause. Okay, so women do have that genetic increased risk associated with heart disease after menopause. And age becomes a risk factor at 55 years of age in women. Women are also more likely to experience angina. And those whose parent or sibling have had heart disease are at greater risk. So, for example, if you have a family history of heart disease, then that individual, regardless of sex, is more likely to develop heart disease themselves. They are at greater risk. It doesn't mean they will. Remember, this is an increased risk. Okay. As far as genetics goes and as far as sex, men are more likely to have heart attacks earlier in life than women. Now, we are going to spend a lot of time this semester talking about alterations to perfusion, because there are many disease processes, conditions in which there is an alteration in perfusion. And this slide gives us a whole list of a variety of conditions, disorders that result when there is an alteration in perfusion. So let me go through this list briefly with you. In terms of clotting disorders, we have DIC, which is disseminated intravascular coagulation. This is a complex process that involves both clotting and bleeding. We also have DVT, or deep venous thrombosis, which is where we have excessive clotting. Now, if we look at the pediatric population, we have alterations to pediatric cardiology in the congenital cardiac defects. When children are born with heart defects, we call that a congenital heart defect, and this most definitely alters perfusion to these babies. More and more these days, children who are born with congenital cardiac defects survive quite well. At this time, we sometimes will have intrauterine surgeries to correct these cardiac defects. Also, we'll do surgery within like the first year of the baby's birth and can correct a good many of these defects. So we don't see this in the adult population very often, these alterations to perfusion, because they are corrected early on. Although we will cover this topic, it's going to be a self-study module in this course, because it's quite infrequent that we deal with it in terms of prevalence. The next disease we'll talk about are cardiovascular illnesses in the adult. And we will talk about coronary artery disease, or CAD. And we see a picture of this on this slide. If you look into the close-up view here, you'll see that yellow plaque forming on the inside of the coronary vessel wall. That yellow plaque is representing the atherosclerosis that has built up and that is narrowing the lumen of the coronary artery. And obviously you can visualize that alteration to perfusion. So that means that all the cardiac tissue distal to that is not receiving adequate perfusion. And then we have myocardial infarction. We'll talk about acute myocardial infarctions. And that is what occurs when there is a blockage in a coronary artery. And that muscle, cardiac muscle, becomes ischemic and then necrotic. And we also see that shown in this picture. We'll talk about that as an alteration in perfusion as well. And then we have common cardiovascular conditions associated with aging. As we age, our cardiovascular system undergoes changes as well. These are normal changes associated with aging. So we will also discuss that as it relates to perfusion. Now we need to address, when we're looking at an overview of perfusion, the prevalence of these alterations. The prevalence is high. Blood pressure, for example, hypertension affects almost a third of American adults. Heart disease, it's the leading cause of death for both men and women. So it's extremely prevalent, and we will see lots of patients in the hospitals with heart disease and hypertension. Heart failure, it's a primary cause of death, and 55,000 people each year die from heart failure. It is so common that there is hardly any way that you can go through clinicals this semester and not encounter somebody who has heart failure. And then stroke. We will see that stroke is also an example or exemplar for alteration to perfusion. We see that over 795,000 Americans every year have a stroke. Some of that stroke leads to death, and some of it leads to long-term disability. So it is extremely prevalent. We see the number of Americans that die each year from stroke is approximately 1 in 20 deaths. Okay. Now let's move on and talk about risk factors for these perfusion abnormalities. Risk factors may be identified as non-modifiable or modifiable. Non-modifiable risk factors are not affected by changes in the client's behavior. They include age, gender, race, family history, and personal health history. These are things that we cannot affect by having them change their behavior. During the client interview, the nurse should ask about family members with health problems that affect cardiac function, or a family history of high cholesterol levels, or early onset of coronary artery disease. These would be very pertinent questions to ask our patients. Because we cannot affect non-modifiable risk factors, we need to focus as healthcare providers, focus on the modifiable risk factors. And these include behaviors like smoking, obesity, physical inactivity. Okay, all of these can be controlled by lifestyle changes. Other modifiable risk factors would be things like high cholesterol, high blood pressure, diabetes. Well, we can change those, or I shouldn't say change, but more manage and control them through the use of medications as well. Sometimes lifestyle changes as well, but certainly through medications. Now, secondary risk factors can contribute to an individual's risk for developing heart disease include things like stress and alcohol intake. Health promotion is very important in detecting through screenings if an individual is developing an alteration to perfusion. What kind of screenings would help in this regard? Well, certainly things like blood pressure screenings, especially when you consider that hypertension is a silent disease. So we should screen individuals to see if they are having high blood pressures. We can also do regular screenings for serum lipid levels. Cardiac function, we can do screenings with an EKG. Again, these are non-invasive EKGs are non-invasive, and we can get a good look at the electrical conduction system of the heart. We can even do stress tests, whether exercise or chemical. We can induce stress to see how the heart performs in response to that stress. Okay, and we do have more sophisticated screening methods such as an electron beam CAT scans, and they can help us to identify calcium blockages in the coronary arteries. So we use these screenings for health promotion and to look for alterations in perfusion. Health promotion also involves lifestyle modifications, and so we do educate our communities, our patients, our populations regarding proper nutrition, adequate exercise, weight reduction in terms of keeping their BMI below 25, the cessation of smoking if they're smokers, and other techniques that will reduce stress, including large muscle exercise and relaxation techniques like yoga and meditation.